So, today we're going to talk about polycythemia, approach to polycythemia, what are the clinical features, how to diagnose a case of polycythemia, and what is the treatment. I am Dr. Amruta, working as a senior resident in the Department of Medicine. So, how do we approach a patient with polycythemia? So, what do we mean by polycythemia? Polycythemia refers to a patient having an elevated hematocrit or a hemoglobin level. So once a patient has an elevated hematocrit or a hemoglobin level, we'll come to how much level we're supposed to suspect polycythemia later. But once we know that it is above the normal range, then we are supposed to suspect polycythemia. Polycythemia can also be divided as primary polycythemia or polycythemia vera, or it can also be a secondary polycythemia, which is secondary to some other physiological or a pathological stimulus. So the first step that we do is we have to measure the RBC mass because there are cases where there will be a relative erythrocytosis as in dehydration where the patient can have a falsely elevated hemoglobin value. So once the RBC mass is found to be elevated, that means there is a true increase in the RBC mass, and that is when we are supposed to consider polycythemia. So once it is elevated, the next step that has to be taken is we have to measure the erythropoietin levels. So once the erythropoietin levels are low, then we'll go into our primary topic, that is polycythemia vera. But let us also see what will happen if the erythropoietin levels are high. So this means that there is a secondary polycythemia and we are supposed to find the cause. That is why the patient has a secondary polycythemia. First thing that we do is we have to measure the oxygen saturation. As a compensatory mechanism, because of hypoxia, the patient can have an increased RBC mass and an increased hemoglobin. So, some diseases like any lung disease or any congenital cyanotic heart disease is very commonly known to have elevated HB in order to compensate the oxygen perfusion to the tissues. So, if that is also not there, if measuring arterial saturation is also normal, then we have to ask if the patient is a smoker. If the patient is a smoker, smoker's polycythemia can also happen, which will normally be confirmed by measuring carboxyhemoglobin levels. That is, you do a usual ABG, and some of the ABG machines can also measure the carboxyhemoglobin levels. If that is also, patient is also not a smoker, then there are different types of hemoglobin that has an increased oxygen affinity per se. So that also has to be checked for. If that is also normal, the patient need not have a normal stimulus which is making the patient produce increased hemoglobin. It can be because of a tumor which is producing increased erythropoietin. That can either be a hepatoma or very commonly a renal cell carcinoma, or it can also be a cerebellar hemangioma. So once we have gone through these steps, usually if the erythropoietin levels are low, then that is where we will consider the primary polycythemia or polycythemia vera, which is the topic of interest today. So what do we mean by polycythemia vera? So polycythemia vera is a clonal hematopoietic stem cell disorder. So there are other clonal hematopoietic stem cell disorders as well. For example, there is chronic myeloid leukemia, there is chronic eosinophilic leukemia, there is also essential thrombocytosis, primary myelofibrosis. This will also come under that group of clonal hematopoietic stem cell disorders. In polycythemia vera, we have morphologically normal RBCs, WBCs, platelets, which accumulate in the bone marrow as well as in the peripheral blood without a physiological stimulus. So if there is a physiological stimulus, we will consider either secondary to hypoxia or secondary to any patient is having smoking or patient is having high affinity of HB, that will come under secondary polycythemia. If none of that stimulus is present, then we have to consider primary polycythemia or polycythemia vera. So what is the molecular or pathological basis behind polycythemia vera? There is one driver mutation which is almost pathognomonic of polycythemia vera, which is JAK2, JAK2 V617F mutation. So almost 95% of the patients will have JAK2 mutation, that is V617F, which is present in chromosome 9. But there is also 5% of patients who are JAK2 negative will have an exon 12 mutation. The difference between an exon 12 mutation and a patient with a JAK2 mutation is that in JAK2 mutation, patient can have all three lineages involved. That is RBC lineage, WBC lineage, as well as platelet lineage. Whereas in patients with exon 12 mutation, they are more likely to have an isolated RBC lineage increased. So now that I'm saying patient can have JAK2, JAK2 mutation, does it mean that it is very specific for polycythemia? No, it is not very specific for polycythemia. Almost 60% of the patient with another clonal hematopoietic stem cell disorder, that is essential thrombocytosis, almost 60% of the patients can have JAK2 positivity. As well as half of the patients with primary myelofibrosis can also have JAK2 positivity. The point to be understood here is these all come under one group of disorders with a common driver mutation, that is JAK2. But if patient is having three lineages increased with some classical signs and symptoms, with bone marrow showing hypercellularity in all the three lineages, with JAK2 positivity, we have to consider the diagnosis as polycythemia vera. So what are the clinical features? So the clinical features will include they have some non-specific symptoms which can happen because of hyperviscosity. That is one possibility. Second possibility is patient will be only incidentally detected to have high hemoglobin or high hematocrit value on routine evaluation or evaluation for another disease. Or the patient can also present acutely with any episode of thrombosis. So now we will look at each and every symptom. So initially patient can be incidentally diagnosed as just high HB and hematocrit as you further evaluate as that was mentioned in the first slide. Once we rule out all the other causes, then we can consider polycythemia vera. And there are patients where they just come to for a routine or a master health checkup and then they find that the patient has a high hemoglobin level. JAK2 has come positive. Patients can have some peculiar symptoms like aquagenic pruritus. So patient tells that whenever the patient takes a warm shower, he tends to have itching all over the body. This is one of the very peculiar symptoms of polycythemia vera. Some of the other symptoms will include because of hyperviscosity, because all the lineages are increased in the blood, patient's blood will be more concentrated with these cells and they can have symptoms of hyperviscosity. Some of the symptoms include tinnitus, vertigo, headache, visual disturbances, transient ischemic attack, and hypertension also. Now, as I told, patient can sometimes present to us in a very acute way. So, patient can have history of any arterial or venous thrombus. So, for example, cerebral. If there is an arterial thrombus, patient can present with a stroke. Or if there is a venous thrombus, patient can present with a CVT, that is cerebral venous thrombosis. Patient will have history of headache, vomiting, seizures. Patient can have altered sensorium and their patient will have bilateral optic disc swelling, which is called as papilledema. Patient can also present with myocardial infarction or commonly known as heart attack. Sometimes patients with myocardial infarction on routine investigation or patient with stroke on routine investigation will be found to have an elevated HB or a hematocrit. Then this will raise the suspicion of a polycythemia vera. This can be the first presentation as well. Sometimes some of the causes of recurrent stroke or recurrent CVT, again polycythemia has to be a consideration. Patient can also present with mesenteric arterial or mesenteric venous thrombosis, Budd-Chiari syndrome. Now, as we know, all the three lineages are affected. Increased RBC has been presented with high risk of thrombosis, hyperviscosity symptoms. Now, increased platelets, ideally we expect more risk of thrombosis, but once platelet crosses around 10 lakhs, patient will have an acquired von Willebrand factor deficiency. So, patient can contrary to our expectation, patient can present with a bleeding diathesis. Even though the platelet counts are extremely high, patient can still have bleeding. And as I told, one of the peculiar features that is there in polycythemia vera is the development of erythromelalgia. So what is erythromelalgia? So the patient will have history of burning or very sharp or very a patient can have extreme discomfort in the extremities, that is in the palms and soles especially during times of stress or when patient takes a hot shower. This is somewhat similar to aquagenic pruritus, but aquagenic pruritus Patients tend to have itching. Here it is more of pain as well as a burning sensation which is present in the bilateral upper limbs as well as bilateral lower limbs. This is also one of the peculiar symptoms of polycythemia vera. Other symptoms will include migraine. Some of the rarer manifestations which are less likely but theoretically possible are because the patient has high lineages, that is high cell numbers because of increased clonal hematopoiesis, patients can have an increased cell turnover. There is increased RBCs, there is increased WBCs, there is increased platelets. That means that these patients have an increased destruction of these cells as well, which is happening continually. So patients can have high uric acid levels in the blood which can present either as a uric acid stone, that is nephrolithiasis, or patient can also present with gout. Some of the other symptoms that are present are because of cytokine release. So this patient can have some fever with chills, patient can have some weight loss, patient can have some fatigue or malaise. But this is less likely to be seen in polycythemia. This is more commonly seen in one of its, sister diseases or whatever you call it. It happens in primary myelofibrosis even more than in polycythemia vera. And as we know, in other clonal hematopoietic stem cell disorders, that is in CML or essential thrombocytosis or in primary myelofibrosis, more than two-thirds of the patients with polycythemia vera will be presenting with splenomegaly. So what is the cause of splenomegaly in this case? This is because of extramedullary hematopoiesis that is happening in these patients. So, these patients with polycythemia are also known to have increased incidence of peptic ulcer disease, which is caused by Helicobacter pylori infection. And they are also known to be having pulmonary hypertension, which will later cause right heart failure, which is nothing but cor pulmonale. So these are the clinical features. Either they can be incidentally detected, they can have some features which are non-specific associated with hyperviscosity, or they can have some peculiar symptoms like aquagenic pruritus, they can have erythromelalgia, or they can present with full-blown arterial as well as venous thrombosis. And these are the very rare symptoms of polycythemia vera. So, how do we diagnose a patient who has come to us with polycythemia? We are suspecting it is primary polycythemia. How do we confirm that it is polycythemia vera? In 2016, WHO has given a major as well as minor criteria for patients to be diagnosed as polycythemia vera. So, the major criteria includes HB has to be more than 16.5 in males or more than 16 in females. And hematocrit has to be more than 49 in males and more than 48 in females. This is point number one. Point number two includes trilineage proliferation, which is proven by bone marrow biopsy. So, what do we mean by trilineage? RBCs, WBCs, as well as platelets, along with pleomorphic mature megakaryocytes. And third thing is JAK2 V617F mutation. But we have to remember that exon 12 can also be present in 5% of patients because only 95% of patients will have a JAK2 mutation positive in polycythemia vera. If this is negative, exon 12 must be considered. So in exon 12, there need not be trilineage hyperproliferation, but there can be only increase in the RBC lineage. So what is minor criteria? As we saw initially, once the erythropoietin levels are low or low normal, then only we come to a consideration of primary polycythemia. Otherwise, it comes as a response. So basically, erythropoietin is produced as a response to hypoxia or any other stimulus or any tumor which is producing high erythropoietin. So here, for the diagnosis of primary polycythemia or polycythemia vera, we need normal or low levels of erythropoietin. So this is the diagnostic criteria which is suggested by WHO in 2016. So as you can see, even if a patient is having JAK2 mutation and patient is having low erythropoietin levels, it is always recommended that we do a bone marrow to prove this as well as do cytogenetic study and karyotyping. So how do we approach a patient with polycythemia vera? Initially what we saw was just generalized polycythemia. Here we are seeing how to approach a patient with polycythemia vera. Once polycythemia vera is suspected, first thing that we do is a JAK2 mutation. So once JAK2 mutation is done, if the JAK2 is mutated, then we directly go ahead with bone marrow biopsy. If it is negative, we can also do exon 12 as well as check for serum erythropoietin levels. If serum erythropoietin levels are normal or reduced, then again we can go for bone marrow biopsy, confirm the presence of trilineage clonal proliferation of cells which are present in the bone marrow. That comes to the diagnosis of polycythemia. So now I have diagnosed polycythemia. We know what are the symptoms with which the patient has come and we have suspected polycythemia and now it is proven. Now, how do we go ahead from this point to treatment? And how does treatment vary from person to person? So as I told, patient can have only incidental finding of an elevated HP or patient can present with a very serious arterial or a venous thromboembolic event uh, or a thrombotic event. So in these cases, the treatment will vary based on the presentation as well as the age at which the patient is presenting with these symptoms. So first step in treatment is risk stratification. So we divide these patients into two groups. We divide these patients into low risk of polycythemia versus high risk of polycythemia vera. So what do we mean by low risk of polycythemia vera? So low risk will include patients who are less than or equal to 60 years of age and there is no prior history of thrombosis. Whereas high risk polycythemia vera includes more than or equal to 60 years of age or there is a prior history of thrombosis. So always remember, whenever you mention about treatment of polycythemia, first thing is risk stratification. And based on this, we have to decide on what therapy has to be given. The idea is we have to give symptomatic treatment, we have to prevent thrombotic events, and also we have to give some drug which will reduce the cellularity of the bone marrow. That is some cytoreductive agent. Cyto means cell reductive agent. So we have to give some agent which will reduce the clonal proliferation of all the three lineages which is happening in the bone marrow so that the symptoms of hyperviscosity, symptoms of thrombosis do not happen and there is also relief of symptoms. So first we'll go look at the low risk patients. So for low risk patients, we have to first step, as we know, if patient is having anemia, the first one of the treatments that we consider is transfusing the patient with packed RBCs. In this case, there is an excess of RBCs. Hemoglobin is very high. So we can do something called as phlebotomy or bloodletting. So once we talk about phlebotomy, there are some things that you have to know. They tell that each session of phlebotomy can reduce the hematocrit by almost 3%. And how many sessions of phlebotomy every person needs? That will depend on what hemoglobin the patient will present with. And there is a target hematocrit. Commonly, I have mentioned here as hematocrit of 45%, but in females, the target hematocrit is 42%. And an adult male, normally an adult male can tolerate up to 1 or 2 sessions of bloodletting per week. But this again depends on how symptomatic the patient is, what is the initial presentation or what is the presentation of HB at the time you want to do the phlebotomy. So as we know, same phlebotomy, the same blood bag that we use, which we use for blood donation, the same bag is being used and each bag can contain almost 350 ml. And we have to maintain proper hydration because these patients, when they get dehydrated, they are more prone for thrombotic events. So the next step of treatment, as I told, first thing is we are trying to reduce the hemoglobin by directly removing the blood. That is point number one. Second is we have to prevent some thrombotic events. So how do we reduce the thrombotic risk? One is to give low dose aspirin. So what do I mean by low dose aspirin here? 50 to 100 milligrams of aspirin has to be given for these patients and it has to be given daily. This is irrespective of whether the patient is having low risk or high risk. Phlebotomy and low dose aspirin is common for both low risk as well as high risk patients. Next, if patient is having some aspirin refractory symptoms, then we can consider treatment of cytoreductive therapy. Normally, in low risk patients, we do not give cytoreductive therapy, but If patient is not able to tolerate aspirin or patient is having some aspirin refractory symptoms, despite giving aspirin, patient develops symptoms, despite giving aspirin, patient develops thrombotic events, then we have to consider cytoreductive therapies. Otherwise, we don't. You don't have to remember this. And we have to also manage the cardiovascular risk factors. Already, patient might have some other predisposing factor like diabetes, hypertension, dyslipidemia. So we have to manage all those because there is an additional risk of myocardial infarction or an acute coronary syndrome in these patients because of elevated hemoglobin. So this is how you treat patients with low risk polycythemia vera. Who are patients with low risk? Less than or equal to 60 years of age, and there is no prior history of any thrombotic event that has happened. So who are the high risk patients? Patients aged more than 60 years, and there is also a prior history of thrombosis which is happening. So how do we treat these patients who are having high risk polycythemia vera? So as usual, phlebotomy and low dose aspirin will be common. That, like I told, how many sessions is needed depends on the severity of the polycythemia. Some patients I have seen have presented with a HB of almost 21. So those patients require almost one per week or even sometimes two phlebotomy sessions per week. But normally patients do not tolerate more than two sessions per week. So phlebotomy based on how much hematocrit the patient is having. Target hematocrit in males is 45%. Target hematocrit in females is 42%. And we also give low dose aspirin, which is again 50 to 100 mg. Normally we give 75 milligrams of aspirin. Next, we go to cytoreductive therapy. So, cytoreductive therapy will be discussed in detail in the next slide, but you just have to have an idea what exactly is cytoreductive therapy. This is a clonal hematopoietic stem cell disorder. I have repeated it multiple times, but this is the only main point that you have to remember in polycythemia vera. So, there is an increase in all the lineages. So, the idea to treat polycythemia will be to reduce the lineages so that you will have less RBCs, less WBCs, and less platelets so that patient can feel symptomatically better. And next, or whatever associated symptoms are there, you're going to treat the patient accordingly. And as I told, there is a prior history of thrombosis, or patient can also present to us acutely with thrombosis. So, what are the possible thrombosis? It can be cerebral, it can be a stroke, or it can be a cerebral venous thrombosis. Cardiac patients can present with a myocardial infarction. Patient can present with mesenteric vascular problems. So patient can have mesenteric vein thrombosis or mesenteric arterial thrombosis. Patient can also present to us with Budd-Chiari syndrome. In all these cases, normal routine, whatever we are using for anticoagulation, has to be continued along with low dose aspirin. So if patient is having a deep vein thrombosis of the lower limb, that can also happen because of polycythemia. So if a patient is having deep venous thrombosis of the lower limb, we can again give heparin, then bridge it with warfarin, and we can continue warfarin treatment with the target INR range in addition to low dose aspirin. So once we talk about treatment, we have divided it as low risk and high risk. The difference between low risk and high risk is only cytoreductive therapy and anticoagulation, because both low risk and high risk will require phlebotomy. Both low risk as well as high risk will require low dose aspirin. Now we will look at cytoreductive therapy. So I've just mentioned the names of these drugs. So there is pegylated interferon alpha 2A. So this drug was initially used as a drug of choice for polycythemia vera, but there are some advantages as well as disadvantages. Some of the advantages of using a pegylated interferon, that is interferon alpha, is that these patients who have a very big spleen, it is known to reduce the spleen size. And also patients with pruritus have found significant relief in patients who have used interferon alpha. But this is a subcutaneous injection. That is one disadvantage. Second is it is less tolerated than hydroxyurea. Hydroxyurea is a very well tolerated drug. It is now commonly used as the most commonly used drug for polycythemia vera. And this interferon alpha is also found to be very expensive. So we generally don't give interferon alpha. The drug that we commonly use, drug that is of choice, is currently hydroxyurea. That is the main cytoreductive therapy. So what is the dose of hydroxyurea is 15 milligram per kg per day. That is the dose of hydroxyurea. So hydroxyurea can have side effects. As you know, the idea is to reduce the number of hematopoietic cells which are happening in the bone marrow. But it can also cause an extreme version where patient can have cytopenia, can have anemia, thrombocytopenia, as well as patient can also have leukopenia. This is one of the side effects. Patients on hydroxyurea can also develop diarrhea. Diarrhea is a very troublesome side effect, and patients can also have peripheral neuropathy. These are the common side effects that you need to know. If you are giving hydroxyurea, always monitor this for cytopenias. Ideally, platelets should not go below 1 lakh. Target will be 1 to 4 lakh of platelets. And diarrhea and neuropathy is also a very distressing symptom. However, it is an oral drug. It is relatively cheaper compared to interferon alpha. Next is busulfan. Busulfan is again an alkylating agent which is not commonly used. Busulfan will be only preferred only when hydroxyurea as well as interferon alpha fails to work. Only if they are not working, you are not able to give, then we have to consider busulfan. But busulfan has a lot of side effects. Some of the very common ones include skin pigmentation, lung fibrosis can also happen. It can cause ILD, that is interstitial lung disease. There can also be a transformation to leukemia. And generally, we don't give or these patients only if patient is very old. If he is not tolerating any other drug more than 60 years, we can consider giving busulfan. So ruxolitinib and anagrelide, they are newer drugs. Anagrelide is more of an experimental therapy. Ruxolitinib, so ruxolitinib. So this ruxolitinib is actually a JAK2 inhibitor. This is commonly used only when uh, interferon alpha as well as hydroxyurea has failed to work. So again, ruxolitinib can also cause cytopenia. It can also cause derangement of liver function tests. That is one of the side effects of ruxolitinib. And anagrelide is a phosphodiesterase inhibitor that is under experimental study. So this is the cytoreductive treatment of polycythemia vera. Now let us just recap what exactly is polycythemia vera and how to suspect, what to do, and what is the treatment. So as we know, it is a clonal hematopoietic stem cell disorder. That is, all three lineages are affected. Most common mutation is JAK2, that is V617F. If it is negative, we have to consider exon 12, which will only involve one lineage. But JAK2 is not specific. Next is clinical features. They can either be incidentally found on routine examination, or if you have a higher clinical index of clinical suspicion, then you can suspect in patients who have a ruddy complexion, who have very non-specific symptoms like fatigue, malaise, or some tinnitus, vertigo, visual disturbances. Or patient can present with full-blown thrombosis, can be cerebral, cardiac, mesenteric, or even Budd-Chiari syndrome. And there are other symptoms also which are peculiar, one being aquagenic pruritus, one being erythromelalgia, and these are rarer manifestations. So once you suspect, this is how you diagnose. So there is a major criteria and minor criteria. Major criteria has 3 points, one being hemoglobin and hematocrit target cutoffs. Second, cutoffs. Second is bone marrow, that is trilineage proliferation has to be there. And the third point being JAK2 mutation. The minor criteria includes subnormal or that is normal or reduced erythropoietin levels. This is to differentiate between primary and secondary polycythemia. So this is what we have discussed. Treatment is very important. Treatment will be dependent on what stratification. This will be dependent on the risk stratification. Patient can either have a low risk of polycythemia vera or low risk polycythemia vera or a high risk polycythemia vera. Both for both these risk categories, common is phlebotomy as well as a low dose aspirin, whereas cytoreductive therapy as well as anticoagulation for thrombosis will be additional for high risk patients. So whenever a patient is coming with an increased HB or a hematocrit, always suspect, first we have to divide as primary or secondary polycythemia. Once there is primary polycythemia, immediately do a JAK2 mutation study as well as an erythropoietin level, and to confirm, to do a bone marrow. We have to first stratify according to low risk or high risk, then give treatment accordingly. Thank you.